Hello and welcome everyone. Today's presentation is Rhabdomyolysis and AKI, how to manage the condition in ICU. First we will see a classic case, a 23-year-old male Arjun Singh who presents to the emergency with severe muscle pain, weakness and cola-colored urine. He had no significant past history and he came to the ED with severe muscle pain primarily in his thighs and lower back. These symptoms developed a day after he participated in intense physical training which was part of his recruitment process in the Indian police services. He described the training as extremely strenuous, which was definitely more than what he normally used to practice. Now after that he developed ache in the muscles which he was not much worried about, but today morning after waking up he has found that the pain has increased and his urine color has changed to a dark cola colored urine. So this has worried him and he came to the emergency. So in the physical examination, he is in apparent discomfort because of the muscle pain. The vitals are stable. There is marked tenderness in the thighs and lower back muscles along with mild swelling with preserved range of motion. In urinary, there is no renal angle tenderness, but there is a cola colored urine which has been sent for urine analysis. In the initial investigations, the creatine kinase is elevated, which is indicative of a muscle breakdown. The urine analysis shows myoglobin, confirming myoglobinuria. The kidney function tests show elevated creatinine and urea, suggesting a renal involvement. So a diagnosis of rhabdomyolysis secondary to excessive physical exertion is made. So let's try to see what exactly is this rhabdomyolysis. Rhabdomyolysis is derived from the Greek word rhabdo meaning rods, myo meaning muscle, and lysis is dissolution, that is breakdown of the skeletal muscles, releasing their intracellular contents into the bloodstream. The condition can occur following traumatic or non-traumatic injury to the muscles, especially the skeletal muscles, which constitute up to 40% of the body mass. So coming to the pathophysiology, this is a muscle diagram, that is a skeletal muscle. It is covered by what is called the sarcolemma. Now the main function of this sarcolemma is conducting electrical signals, maintaining the ion balance and hosting the receptors and channels, connecting the interior to the extracellular matrix, regulating the nutrients and waste exchange. So how does rhabdomyolysis occur? It occurs when there is a damage to this sarcolemma by any cause. It can be a traumatic cause and there can be non-traumatic causes as well. Now let's see what the causes are. The traumatic causes are like something like crush injury, strenuous exercises, seizures, alcohol withdrawal syndrome, limb compression, or you can have non-traumatic like genetic disorder, especially the disorders of glycolysis or glycogenolysis, disorders of the lipid metabolism, mitochondrial diseases, infections like influenza A, B, Coxsackie, Epstein-Barr, body temperature changes like heat stroke, malignant hyperthermia, metabolic and electrolyte disorders like hypokalemia, hypophosphatemia, hypocalcemia, drugs and toxins. These are also important causes. We'll look into more details. The important drug is lipid lowering agents like statins and fibrates, both of which are quite commonly used. Psychiatric illness drugs like haloperidol, SSRI, lithium and valproic acid. Antimicrobials like trimethoprim, sulfamethoxazole, quinolones, amphotericin B, anesthetic agents like succinylcholine and propofol, antihistaminics and other agents like narcotics, vasopressin, colchicine and steroids can cause this condition. The use of illicit drugs like cocaine, amphetamine, hallucinogens, heroin and LSD can also precipitate rhabdomyolysis. So what happens is once there is a damage to the sarcolemma, there is an increase in the calcium inside the muscle. With that, there is a decrease in the ATP. This also is aggravated with the release of myoglobin due to the muscle breakdown. Now, this schematic diagram summarizes this. With toxin infection and trauma, what you get is a sarcolemmal muscle destruction. This all can also lead to muscle ischemia, all of this leading to both influx of calcium as well as decrease in the ATP. Now, with the influx of the calcium, there is persistent muscle contraction, activation of the calcium dependent proteolytic enzymes, lipid peroxidation and myocyte degeneration, resulting in what is called rhabdomyolysis. Now in ischemic conditions, once the reperfusion occurs, there will be an increase in the inflammatory cells into the areas where there is muscle destruction. So in those areas you will find inflammatory cells, release of cytokines and free radicals, further aggravating the systemic condition. Now how everything affects the kidney now. Now kidney is affected because first what you get is a fluid sequestration in the injured muscles, thereby decreasing the intravascular volume. Next what you get is activation of the vasoconstrictor systems, which will decrease the blood flow to the kidney. Apart from that, you will get specific renal vasoconstrictions resulting in ischemic damage, direct tubular injuries, ischemic tubular damage, and finally distal tubular obstruction because of the myoglobin casts. So this is a diagram again summarizing the whole thing. Here you can see once there is muscle breakdown, you will have the movement of fluid from the intravascular surface into the skeletal muscles, thereby resulting in fluid sequestration in the muscles and decreased intravascular volume. Apart from that, you will have release of potassium and phosphate into the circulation and calcium going into the muscles, thereby causing hypocalcemia. So all these conditions result in what is called the activation of the RAS, SNS and ADH release, which will decrease the renal perfusion, causing renal vasoconstriction. Apart from that, the myoglobin per se can also cause damage. The released heme will produce free radicals and cause direct injury to the proximal tubules. Apart from that, the distal tubules are also affected by the casts which are formed, that is myoglobin precipitating with the TAM horsefall protein here, thereby causing casts and obstruction of the tubule, and all these conditions result in what is called acute kidney injury. Now the symptoms are muscle pain, weakness, tenderness with potential swelling and skin changes indicating pressure necrosis. These are mild symptoms, but you can get severe complications like dark urine, hyperkalemia, hypocalcemia, elevated liver enzymes, cardiac dysfunction and cardiac arrest. Now the difference in presentation can vary among various populations. Like in elderly, rhabdomyolysis may be more subtle, which is discovered only after the patient falls or there is a stroke. And in patients who have substance abuse, these symptoms may be masked because of the intoxication and other comorbid conditions that may exist in this population. Now clinical variability also exists despite this classical triad that we have read till now, that is muscle pain, weakness and dark urine. These features are seen in less than 10% of the cases, and over 50% may never ever complain of any muscle pain or weakness at all, making our diagnosis very difficult. Now the presentation can vary significantly based on the underlying cause and the patient population. Now diagnosis. Before we go into the diagnosis, we must know two important differential diagnoses we must know for rhabdomyolysis. The first is the differential diagnosis for differentiating for the dark colored urine. So you must know how to distinguish between a myoglobinuria, hematuria and hemoglobinuria. Next is inflammatory myopathies. These conditions like dermatomyositis present with muscle pain and elevated creatine kinase levels, but in these cases the presentation is more protracted and not acute as we saw in our index case. So first you make a clinical suspicion based on these symptoms like muscle pain and dark colored urine. Once that is done, take a good history to find the precipitating cause, that is a trauma or strenuous exercise or seizures or toxins, endocrine diseases, autoimmune diseases or any recurrent episodes. Once you have done that, next you run a battery of tests, that is especially the first one is creatine kinase, where you look for more than 5,000 international units per liter of the elevation. Next in urinalysis, you look for myoglobin, check for renal function, that is creatinine and BUN, check the electrolytes because potassium and phosphate are going to go up, calcium is going to go down, CBC can also be checked and 2-lead ECG for elevated potassium. Apart from that, for prognostication purpose, you can check the serum albumin level, which will be low in severe cases, and coagulation panel, where it can be deranged if the rhabdomyolysis has precipitated a DIC. Now, how to know if it is a recurrent case or I should be worried of recurrence? For recurrence, you need to, the patient comes with recurrent episodes, then quite obviously it is a recurrent case, or the hyperkalemia persists 8 weeks after the event. There is an event which has been precipitated by accustomed exercise, which means that the patient has been exercising like that for many days now and suddenly these symptoms have developed. It has to be an unaccustomed exercise which must trigger this event. Next, what you look for is the blood levels of the creatinine kinase. Next is drugs and medications and supplements. You need to look for other causes where the use of these drugs has been going for a long time and that has been no such increased usage which could precipitate this condition. Apart from that, if the family history there, and obviously you should look into the recurrence. So first is urine analysis. There you look for the heme, which will come positive. The pH will be acidic. The protein is positive. The color is reddish brown, and microscopic analysis and urine sedimentation will show myoglobin casts. Apart from that, you do the ABG to evaluate the acid-base station, ECG for the electrolyte changes, CBC to check for hemolysis and infection, coagulation parameters because it can precipitate a DIC, serum albumin, as I said, it indicates capillary rupture and leakage, toxic screen for causative agents. So this is a table summarizing all of the things that can possibly happen over here. So you must need to understand each thing that has happened so that you make a quick diagnosis based on the parameters that have been shown over here. Regarding muscle biopsy, timing of biopsy, it is best to wait for weeks or months after the event, as early biopsy may appear normal or show non-specific necrosis. Metabolic myopathies, the biopsies are particularly useful if metabolic myopathies is suspected. Now different stains like PS, that is periodic acid shift, or hematoxylin can reveal increased glycogen or lipid content, indicating possible glycogen storage disease or disorders of the fatty acid oxidation and mitochondrial cytopathies. Apart from that, immunohistochemistry can be done to identify specific enzymes. Regarding the management, first you need to classify the disease into its severity. This is done based on the CK levels, that is creatine kinase level. That is mild rhabdomyolysis is 1000 to 5000, moderate is 5000 to 15,000, and severe is more than 15,000. Once it is moderate to severe, consider the patient is having a high risk of renal injury. Now apart from that, there is one more scoring done, that is McMahon's risk scoring. This can be done based on all these parameters. With this also you can do a classification of risk for renal injury or mortality. If the score is more than 12, then the mortality is as high as 60%, and if it is less than 3, then there is a very minimal chance of mortality, and if it is more than 6, there is a high chance of acute kidney injury. So based on this, once you check the CK levels and you find it is less than or it is mild, then you look for the McMahon score. If the McMahon score is less than 6, then you probably don't need to do anything. If it is more than 6, then we will give fluids. We will go into the details of this part later on. If it is moderate to severe, again we will go into and give the fluids. Now let's discuss about the fluids. Regarding the fluids, a lot of studies have been done. Most of them are retrospective. There is a few prospective study with not much inference to be drawn from there. So there was a meta-analysis of all the possible studies done till now, and in this they found that fluid must be administered as early as possible, preferably within the first 6 hours. Apart from that, fluid should be administered at a rate that maintains a urine output of 300 ml per hour or more for at least the first 24 hours, unless a medical condition precludes giving enough fluid to meet this goal. Now increase the soda bicarbonate to be administered if necessary, that is if there is systemic acidosis. Apart from that, you can also try mannitol. We will go into the details again later. Now volume replacement, early and aggressive, should be done as has been told. It is key to preventing AKI and aims to restore the renal blood flow and increase the urine flow, thereby minimizing the tubular cast formations. AKI risk increases with delayed hydration. Up to 10 liters per day the fluid may be required in some cases. Fluid choice can be anything. You can give both lactated drink and a normal saline. In the Cho et al. Trial, they found that there was an increased requirement of bicarbonate if you are giving normal saline. Monitoring initial rates of 1 to 2 liter per hour, adjusted based on CK levels and urine output to avoid volume overload. Now maintain hydration until rhabdomyolysis resolves or the CK levels drop below 5000. So now if we find that the patient is having a risk factor of AKI, that is moderate to severe disease or mild disease with a McMahon score of more than 6, then first evaluate the volume status. This you do by the history, the intake output, the weight changes, the physical examination, that is look for peripheral and pulmonary edema, echocardiography findings. Once you have done that, you may find the patient in 3 conditions, either hyper, U or hypovolemic. If hypovolemic, then I will not give any more fluids. If the patient is hypovolemic, I will do a volume resuscitation and assess euvolumia. Once euvolumia is assessed, then I will give small challenges of fluid hourly and check how the patient is doing. And later on, by monitoring and checking the urine output, I will titrate my fluid that is to be given. Urine alkalinization. Bicarbonate has anecdotal benefits in some patients, and alkalinization prevents myosin cast formation, reduces the redox cycle of myoglobin, and decreases the tubular damage. It is recommended for severe rhabdomyolysis, especially when the CK levels are high and they are also rising. No hypocalcemia must be present, and the arterial pH must be less than 7.5 and the bicarb must be less than 30 before I can use this thing. And regarding monitoring, start with 200 ml per hour, targeting a urine pH of more than 6.5. Monitor arterial pH and serum calcium levels at all times. Now, if the urine pH remains low and hypocalcemia develops, or if the arterial pH or the bicarbonate levels are exceeding the safe limits, I need to discontinue the therapy. Next is, there is very limited evidence for its effectiveness to actually do this, but most data is coming from uncontrolled case series. Now regarding mannitol, as an osmotic diuretic, enhances urine flow and enhances the intrarenal heme pigment trapping, and its effectiveness in rhabdomyolysis is unclear with conflicting results from retrospective trials. Can cause volume depletion, hypernatremia, and at high doses it can also cause renal insufficiency, can lead to hyperosmolarity and hyperosmolar hyponatremia. Now, may benefit patients with severe rhabdomyolysis, but its overall benefit remains certain. Now, the thing that you need to remember is, till now what we have discussed, that is the volume resuscitation, the mannitol and the alkalinizing of the urine, is for AKI prevention and to prevent a dialysis. It is not to be done in cases where the renal failure is established and I am already in dialysis. So it has preventive role. Now manage potassium. Frequently monitor every 4 hourly and monitor the heart irregularities caused by the high potassium level. Consider ICU for potassium more than 6 or ECG changes. Now monitor serum calcium, as hypocalcemia can worsen the effects of hyperkalemia. Use insulin and glucose and possibly sodium bicarbonate, that is the common potassium lowering agents that we use. For potassium removal, you can use the cation exchange resins, diuretics and hemodialysis. The point to be noted is, monitor rebound potassium increase in post hemodialysis, because that can happen in these particular cases. Prevention. High risk population, identify and monitor the individuals who are at high risk, especially the athletes or patients with certain medications. In those patients, what you can do is check for the triggers, educate the patient to avoid such triggers like physical exercise, substance abuse and dehydration. Patient education should be done to, especially the high risk cases, to inform them if these are the symptoms, you must come to the hospital, and lifestyle modifications to prevent these things from happening. Regarding the healthcare providers, they need to be educated for early diagnosis, early recognizing the symptom, patient counseling so that they are counseled properly to come to the hospital once they develop such symptoms, and finally follow up. So regarding the recent advances in research, the recent advances have not been much because there is no RCT. Most of the data that you have seen till now is coming from retrospective observational studies, animal models, case reports and series, and expert opinions. Regarding emerging therapies, there is no emerging therapy as of now, but recently papers have been published which have been looking into the role of heat shock protein in rhabdomyolysis pathophysiology and how it actually aggravates the disease process. Now what we need to understand is, these are still experimental stages. We still don't know what targets we will find and how can we use those targets to reduce the severity of the disease process. The next is summarize. So what is the take home message? If a patient like that comes, the initial assessment is suspect rhabdomyolysis in patients who have muscle pain, weakness or dark urine. Check for risk factors, that is trauma, exertion, drugs, toxins and infections. Diagnostic test, do your CK levels. Check the renal function, electrolytes, perform urine analysis, check for myoglobinuria, ECG for cardiac complications. Treatment, fluid resuscitation, early and aggressive electrolyte management, urine alkalinization and mannitol can be used in severe cases to prevent the progression of the renal disease. How to monitor, check regular CK levels, renal function and electrolytes, monitor urine output and adjust your fluid strategy accordingly. Regarding complications, once the patient has developed AKI, you have to go for dialysis and monitor your electrolytes. Regarding the follow-up care, consider monitoring the CK levels and renal function normalization. If they do not normalize, it must be kept in mind and proper action should be taken. And finally, address the underlying causes and prevent recurrence. Thank you for your patience.